So I think now we can move to our next topic. Our next topic is by our president, Dr. Lalit Verma. We are meeting him after a very long time, and we have learned so much from him. And I think also today we all will learn a lot from him. He'll be speaking on my infusion cannula is not in position, subretinal or suprachoroidal displacement of the infusion cannula. So please.
Thank you, Bhuvan, for making me part of this interesting session. In fact, all veterinary surgeons have nightmares virtually every operating day. And especially if you have some issue, I generally cannot sleep on that day because of whatever trauma I may have caused. So therefore, I believe in minimal possible manipulation. Otherwise, you tend to cause a lot of iatrogenic issues. So I'll be describing one or two cases where I have faced this situation of subretinal cannula. So no financial disclosure. So in all vitrectomies, everybody is taught first in, first out, and there is no compromise on this. And before we start vitrectomy, it is mandatory to check the location. But there are situations where issues may occur, like a bullous RD, where you see people go inside, and where thickness is expected to be more, something like CD along with RD, uveitis patient, choroid is thicker, or a hypotenuse globe, or endophthalmitis, small pupil. So these are practical situations where I have found, this situation may occur, that cannula instead, even though you may take all precautions, it can. So I'll illustrate by this small video. This was a patient where we were doing vitrectomy. You see, first port made here, and you could see that that MVR was inside. You could see this location. There was some tissue here, so I was not very sure whether, so made the other port. This is a port straight vertical. In such situation, don't go a two-plane incision, go straight inside. Actually, this should have been made in the opposite quadrant. And then, try to cut this tissue, which is obstructing the view, and you may have to depress it. But if you make this port here, opposite, then you will do a better job. And just cut this tissue and remove that, and then check again whether it's okay or not. So this was a patient of endophthalmitis, where we were, doing a vitrectomy. So here again, the only trick here was to do a needle infusion. Take this sharp needle and infuse ringer lactate or BSS, what you're doing, and make the globe slightly firm. This is a hypotenuse eye. Once you have made the globe firm, then you can take this cannula again, single entry, straight entry, rather than a biplanar or triplanar entry, because of thickness of the choroid, and go straight inside, because this cannula is more likely to be inside rather than the curved. Now you can see, now you do all the intravitreal maneuvers. So this was one recent patient which we were doing. This was a young gentleman, decreased vision for a pretty long time. The anterior segment slit lamp had evidence of uveitis with synechia, but patient had a detachment also, had cataract also, irregular pupil. So challenge was whether to do cataract surgery, combine it, do a lensectomy, or eat away the lens at that time. So mentally we prepared for each and everything. So this was the fundus picture. BCVA right eye 6/60, predominantly nasal RD. You can see part of the retina here superiorly attached, but you see nasal part is detached, but macula also is off. So let's see this surgery. So here, biplanar, you can see this, pigment on the surface of lens. And then I did depress. If you noticed, I did depress here and see here that, it is inside. So we started doing the vitrectomy. Initially, you could see, but now the illumination has decreased suddenly. This cannula, the light pipe is seemingly subretinal, but I continued. I did not take out this light pipe. You can see this reg component here. A lot of pigment on the surface of retina. Then on the right side, because it was inside, we injected PFCL, some amount of PFCL, just to displace take out this fluid, and did as much vitrectomy as possible. So this time I realized more job has to be done. There was some PVR, so took a chandelier 25 gauge. Now illumination is very good. So if there is sudden decrease in illumination, you should be, that's a red flag sign. And then you peel off this membranes, and there are multiple breaks you can see here in the upper part also. And remove this PVR, localized PVR here. And whatever membrane dissection you can do, you should, without much change of instrumentation. If you keep changing instrumentation, then it's an issue. So, in any case, we tried to remove all these membranes here. Then usual principles of ER surgery, diathermize all the breaks so as to identify them during fluid exchange. And then I removed the PFCL. Notice what is happening is this retina is becoming balloonous now. This just does happen once you remove this. And you see this air is coming in the subretinal space. This was, I hope you noticed that once we started airflow exchange, remove the PFCL. This is the air part. In the lower part, there's air in the subretinal space. So again, this became subretinal. So put another, remove this infusion cannula from the infratemporal quadrant, made another port. Now this eye has 5 ports inside. Did not touch the lens till now, this stage. Now it has become again very nice, and once we remove this air from this retinal break here, this was the air, this will come out, and then did the routine airflow exchange. Now this patient had multiple breaks, one of them was iatrogenic, and others were pre-existing superiorly as well as inferior. This patient already has had procedures done before. So then you do complete the airflow exchange. Now it's reasonably nicely settled retina, put in the oil, and do a reasonable good amount of laser in all the retinotomies, iatrogenic as well as the pre-existing. There are 4 or 5 breaks here. So the lesson learned from this patient was, this was the post-operative picture. The nasal retina, everything is well settled. Patient did gain 6/18 vision. Siliconal reflexes are still seen. These are a couple of pictures I gathered during the surgery from the camera itself. So if the tip of the port is not visible, obviously nobody will venture and start. But if the illumination suddenly becomes less, so you should be cautious that why is this happening. Or if the RD becomes suddenly balloonous, be very, very careful. Or if the air goes separately, as I showed in the last video. It's very important that avoid frequent change of instrument. Otherwise, you may create dialysis by forcibly inserting the instrument through the trocar cannula, and sudden movements can lead to a lot of issues. And try as much as possible to maintain your calm. Very important is to change the position of the ports. This is, I think, the best part. Take a chandelier and change the position of the ports. And port entry should at this time be 1 step and vertical rather than 2 step and angulated. Especially in situations, as I had mentioned, uveitis and end of my patient, this patient had uveitis and a hypotenuse eye. So such patient always start with a vertical entry. And you may, end up avoiding multiple punctures in the choroid. So this is what I wanted to share, 3-4 cases where I had personal issues and how we manage this.
Thank you,
So
sir.
if anybody else has experience of this, I would love to hear and maybe
please.
share.
Any comments from the audience?
If you thought you saw the infusion cannula but were not quite sure, almost always it is subretinal. So it's better not to pursue. If you have the slightest hunch that you have not visualized it, it's better to assume.
No, first time when I started, we saw it, therefore we started.
No. I'm just making a
Yeah,
general comment.
yeah, that's true.
And the second point which you made
It may, you're right. It may happen in the beginning, or it may happen intraoperatively also. Once your retina suddenly becomes balloonous, it can happen suddenly also. After you have started with a very good protocol that you saw it, everything was good, like this patient, then it can become subretinally during surgery.
The other way of trying to ascertain whether it is intraocular is to put on the indirect and see the and press down. Another point which you may add to that list is when you turn on the infusion, the globe doesn't quite firm up if it is subretinal. So that should be a subtle hint that it's not in the right place.
Yeah. You see, I 100% agree with you, but problem is during the procedure. Initial part, I think everybody will take precaution, whether needle infusion or like you were saying infusion. But problem I faced was during surgery it happened. And during surgery then you are uncomfortable. That what to do, what not to do, because especially if it is a complicated patient, media compromised by uveitis and cataract, so then it becomes an issue. Then I think best is to change the ports and go straight. Rather, and initial part you have to maintain calm, that do not force your instruments inside. If you force the instruments, then especially upper nasal areas, you may create a dialysis or a break there. So you have to be very, very gentle. Whatever you are seeing, very, very slow, gently you can do. Because it's a myth that, once retina becomes balloonous, this retina with vitreous can get incarcerated there also if you move too much.
Excellent teaching points, sir. I just want to add about the intraoperative cannula disinsertion. So a few areas where we should be careful, like during indentation in that area, your assistant might not be very well trained, so he might disinsert that cannula or partially disinsert, so it's in the suprachoroidal space. And the second is while you're doing a GA case and the patient becomes light sometimes and there is a violent movement, and that is one area where the cannula can go into the suprachoroidal space. There's a few points we have to constantly see again and again whether the infusion is inside or not.
Excellent, Vishal, because I also encountered one of this, because the room generally becomes dark at that time, and if the assistant is not very careful, if you are not, you're shouting too much, so if he will move the lens or something, suddenly this infusion cannula will come out, and then you may have issues.
Thank you, sir. Always, we listen to Dr. Lalit, we learn a lot. Just one or two points which I've practically experienced. One is whenever we are all using MIVS these days. These cannulas we are using and reusing. So the cannulas may become a little they may not be locking. So make sure that once you put your cannula that it will lock it. Second thing is put a tape on the tubing that comes so that the assistant cannot remove it. Third, in cases of doing a choroidal detachment, I still use a sutured 6 mm cannula rather than using an MIVS, because I want to be sure that I'm inside. I do a hybrid vitrectomy, I do a sutured, I still have a MBR blade, I still have a 20 gauge cannula in my OT, so that if required we can use that. So don't shy from doing that.
So no, I agree. This is another practical point which Ajay has told, that put a tape there so that movement is restricted or less. So minimize the chance of sudden jerks. So both these points, I think Vishal and Ajay, we should add to this list, that sudden removal of this. Thanks. Thank you so much.
Sir, just to conclude, I would just please, if you could just highlight the signs which we can see if our cannula is displaced subretinal or suprachoroidal, just before to conclude. The signs, intraoperatively, what will happen suddenly that we should fear that something has gone wrong with our cannula?
RD will become suddenly balloonous, your view will be lost, you will not be able to, whatever you are doing, you will not be able to see much. And if RD suddenly becomes balloonous or choroid detachment starts happening, then it's definitely something wrong. So at that point of time, plug it, and then what I will do is take a needle infusion or a AC maintainer just to firm up the globe, and then reassess and do maybe indirect at that time, and then restart the entire thing.
So one very specific point which I have noticed is that the turbulence, the movement of the intraocular fluid becomes absolutely static if the cannula is not in the vitreous cavity. Suppose you have injected tricot for PVD induction. Normally if you aspirate the tricot, the crystals will move in a very rapid way into the port, if the cannula is in the vitreous cavity. But if it is in the suprachoroidal, it's not moving, it's just stuck there. So that is something wrong.
So absolutely. Correct. The dynamics inside the eye will change. Same like when there is a vitreous loss during cataract surgery. So you come to feel that something is going wrong. The RD starts becoming balloonous, the vitreous is not sucking, the fluid is not coming. So you have to be very careful. And sir, just one point, I think you have mentioned already.
If those instruments are not obeying what you are doing, suppose I am pressing the foot switch and it's not happening, the crystals are not moving, tricot crystals, there should be an alarm.
And with this MIVS thing, it has become easy, as sir has also piloted. By indentation, there are high chances of the cannula going subretinal. So another advantage is you can just remove the cannula and put it at a different site, so that you have to be fast, because the more late you become in this, the more chances, the more difficult it becomes.
Yeah, if you indent too much, then the cannula is like this. If you indent too much, this will become subretinal.
Sir, can I make a point?
Yeah.
Sir, also with valved cannulas, this issue is less, sir, because the turbulence when we move.
Turbulence is less.
Less.
Also using.
You see, in India, problem is all these things are very good points, but all of us can't afford valve cannulas. A new patient, every time. So the valve becomes ineffective after 2 or 3 cases. So you are right. You see, as far as possible, we should use valve to avoid turbulence and maintain fluid dynamics. That is the best, there's no doubt about it.
But sir, just I want to make a point, even with valve cannulas, this problem is there while indentation, because I had it just recently, because when you indent it, as sir said, the direction changes and there are chances it may go into the suprachoroidal or the subretinal space,
So
whether
these
wild
are
or non-wild.
all these are some tips to minimize all these issues.
Even using 3 millimeter or 3.5 millimeter, not going to 4 millimeter, even in phakic eyes, it will reduce the incidence.
Yes, yes.
As a beginner surgeon, we always face organized vitreous hemorrhage or dense vitreous hemorrhage. Many times you cannot see the cannula at all.
Yeah.
So, how you advise to?
Yes, you want to make a point? Yeah.
Wanted to make a point.
From this angle? Yeah.
Yeah. So in case you cannot see the cannula, if you think
Because of dense opacity there.
because of dense opacity, like in endophthalmitis, you can initially do your vitrectomy core and the anterior vitrectomy with AC maintainer also.
Yeah, even in phakic eyes you can put AC maintainer
We can
in
put
case.
AC maintainer until we are able to see the get enough amount of clarity in the vitreous. Then we can put the
You see, what I would do is I will do a core vitrectomy and then indent, too heavily, and with the left hand try to, remove that muck or with dense hemorrhage around the cannula, and be very careful not to touch the lens at that time, because the direction of indentation should be not like this towards the vitreous cavity, and then you can, loosen that tissue.
So,
it may take some time.
your point of a dense vitreous hemorrhage, I am not able to see the cannula, or an endophthalmitis, I am not able to see the cannula. I will not start my cannula. I will take the infusion with a hard tip in the other port, which means I'll go well inside in the mid-vitreous cavity. When I'm sure before, if I've done an ultrasound, there is no detachment, I will start my vitrectomy. I don't need light because the microscope light is enough for me to do an anterior vitrectomy. Once I've done the anterior vitrectomy, I can see the cannula and you're done.
So the other thing you can do is second case which I showed, to take a needle infusion and connect it to the infusion. Needle will definitely be inside. Needle will definitely, you can see, and then do a vitrectomy, and after you have done most of it, then recheck infusion and do it.
So there
needle
are
infusion does work, or AC maintainer also does a good job.
Yeah, just to conclude that point of your not seeing the cannula, there are very few cases you cannot see the cannula. So there are two ways of seeing the cannula. First is you manually indent that cannula part and see the tip. But sometimes, like you said, in dense vitreous hemorrhage, it cannot be visible. And going with the needle from the opposite port is not always visible in phakic eyes. You might have a risk of touching the lens. So if there's a dark room, you switch off the microscope light, take the endo illumination, and from the opposite side shine it. And that steel part of the cannula will be visible even in very dense hemorrhages. So that is one way. One way is indenting manually, and the other is shining that cannula, the steel part of the cannula with the endo illumination. That the cataract surgeons also use the endolight in hazy corneas to do phaco these days. So that's a very useful
Chandelier
technique.
assisted care, yeah.
So I think excellent discussion, and I think the last question was very important. Very important point. You should not switch on your cannula if it is not visible. I think this is
Period.
the
That is
most
period,
important
yeah.
thing. So what you answered, everybody has cleared all your doubts. But if you're still not able to visible your cannula, or if your cannula is visible and it is in the subchoroidal space, then it is a problem. So in phakic eyes, it is always difficult to go from the opposite port. So what you can try is you can go from the port which is present above. So what normally is recommended in pseudophakic and aphakic eyes, you go from the opposite port with a cutter or anything, you indent it and you try to release it, and when the tip is visible, it's good. And in a phakic eye, you can try to go from the port which is present above it, rather than going from the opposite port, to prevent the risk of lens touch. But you have to be very careful. The tip should be visible before you proceed with further surgery. Or probably even you can change the direction of the cannula if the tip is not still visible or is in the suprachoroidal space.
Sure.
Okay. Thank you, sir. Thank you very much. I think it was a very nice talk, very learning talk for everyone, and a very nice discussion.